Hello everyone. In this presentation, I would present the case for bone patellar tendon bone graft as to why it could be a graft of choice in some scenario, and we'll also share some technical tips on how to avoid the complications and difficulties associated with this procedure. As we review the literature, our ACL reconstructions are not doing as great as we want them to do. While many systematic analyses say there is no clinical differences between hamstring ACLs and BTB ACLs, some studies have pointed out that hamstrings may have a high failure rate. In a nutshell, BTB is a patient-friendly graft. For a surgeon, it can pose some challenges, and hamstrings have definitely eased our life. But for both the surgeon and the patient, at least in some instances, we should bear the short-term pain of BTB for a long-term gain. The definitive indications for BTB would be a contact athlete, a sport like climbing where you want to preserve the hamstrings, patients with risk factors which can result in a primary ACL failure, especially young athletes at their prime, hyperlaxity, increased slope, and increased recurvatum. BTB graft is my graft of choice in revision surgery where the bone plug can be used to fill up even large tunnel enlargements with ease. I would not do BTB ACLs in those who already have anterior knee pain, quadriceps weakness, previous injury, and those who require kneeling as part of their lifestyles. And hamstring graft may be preferable in patients who have gross patella alta or baja, and women who are very small and short may have a very thin, narrow strip of patellar tendon. The BTB graft is taken using an oblique incision, which starts from about a centimeter below the inferior pole of patella, which goes obliquely down and medial to a point 1.5 centimeter to 2 centimeter medial to the tibial tuberosity. This is a video of BTB harvest. Through an oblique incision, the patellar tendon is exposed. A midline incision is made on the paratendon, and it is reflected medially and laterally. The central third of the patellar tendon is identified, and the width of 10 millimeter of patellar tendon is marked and incised. Now a cotton tape is passed under the tendon to enable us to retract. The incision is extended on the tibia to around 3 centimeter of tibial bone distally, and then the end point is also marked with a knife. Now the saw is used to make a cut at 45 degree in a converging manner to get a graft with a rhomboid cross section. Now the medial cut is being made. The inferior distal cut is also being made. So very important to connect all the cuts. The superior cut is made 9 to 10 millimeter above the tendon insertion using an osteotome to get a tongue of bone attached. If you have done your cuts properly, just gently tapping with an osteotome would release the graft. And then the graft is carefully taken out, the knee is extended, the graft is wrapped around in a lint, and the patella is pulled down into the wound. The intended cuts on the patella are marked with a knife. 8 to 9 millimeter of width is aimed in the patella. The superior cut is also being marked. The use of the saw, the lateral and medial cuts are made to a depth of around 8 millimeter. It's very important not to go too deep, and it is also important not to make a cross hatch when you're doing a superior cut. Once the superior, lateral and medial cuts are made, the starting point for the inferior cut, the coronal cut, is marked with an osteotome. An impression is made with an osteotome. This impression serves as a point for saw blade so that it won't skive off. And now an osteotomy is passed into the coronal undercut, and the graft is lifted after freeing from the soft tissue attachments. The bone plugs are provisionally sized, prepared. Ideally, we would aim for an 8 to 9 millimeter of patellar bone plug and 9 to 10 millimeter of tibial bone plug. Using an 1.2 mm drill bit, drill holes are made in the tibia, and normally 2 drill holes are made in the patellar bone plug at 5 millimeter apart. On the femoral side, graft passage, tunnel blowout, screw insertion, and screw spinning around the graft while inserting the screw, breakage of a bioscrew if you are using a bioscrew, and damage to the graft by the screw threads, the graft laceration, are all the problems one could anticipate with this technique. In the transtibial technique, the line of pull of the graft is nearly straight. But in a transportal technique, the BTB graft has to negotiate 3 different directions. And also, the bone plug has to turn and negotiate itself into the femoral socket inside the joint. To facilitate the easy passage of the graft, sometimes we can overdrill the tunnels by a millimeter so that the graft pulling and passing will become easier. A shorter patellar bone plug, say around 18 millimeter, will facilitate easily to turn in the notch and to manipulate the plug into the femoral socket. And it's very important, one should not apply too much pull on the femoral bone plug as it can result in graft damage. And once the tibial bone plug enters the tibial tunnel, it can be pushed from below along with pulling of the femoral plug above. It is important to clear and expose the notch properly so that you can place the femoral tunnel properly. And it's also important to drill the femoral tunnels in a sequential manner, verifying at each step that the intact posterior cortical rim is preserved. Notching of the tunnel anterior superiorly with a notcher or with an osteotome will facilitate the placement of guide wire and also provide a track for the screw to go parallel to the graft without spinning around the graft. Damage to the graft by the screw threads can be avoided by flexing the knee to 120 degrees during the screw insertion. And also one can use a graft protection sleeve like this around the screw while the screw is inserted into the femoral socket. This video of a revision case, you can see the BTB plug is attached to an adjustable button loop, and then the loop is shortened, pulling the bone plug into the joint. You can see I'm using a probe to direct the bone plug into the tunnel, and the junction of the bone plug and the graft is marked with a marker. And you can also see the presence of the notch, which allows us to pass the screw easily, and the guide wire is passed parallel to the graft. And because of the liberal notching and also the protection afforded by the graft protection sleeve, we can insert the titanium screw with ease in this case. On the tibial side, the major problem would be a lengthier tendon portion, which would result in a graft tunnel mismatch. The tibial bone sutures may cut out, or the plug can break, or the tibial fixation could be very weak. We will see in the coming slides how to tackle these potential problems. Small amounts of graft tunnel mismatch can be accommodated by making the femoral tunnel purposefully longer so that we can pull in the graft 5 millimeter or 10 millimeter deep into the socket and fixing them. And also it's very important when you're doing a BTB ACL reconstruction, the tibial tunnel should be made slightly longer. For this, I always keep the jig at around 65 degrees. If you anticipate the problem of graft length mismatch, one can opt for this BTB fold-over technique, in which the saw is used to thin the patellar bone plug. The bone plug is made thin to around 5 millimeter thickness, and then it is folded over a loop of an adjustable button system. Provisionally, the size is measured. Then the sutures are taken through the holes in the patellar bone plug and then onto the tendon. Now the bone plug is folded back onto the tendon, and the sutures are tied, encircling the tendon around the bone plug. We have made two drill holes in the patellar bone plug. The second hole is once again used to take the suture through the bone plug and through the tendon. Once again, you are coming through the bone and through the tendon. Now, both the ends are brought in on either side of the tendon. Now they are brought around the bone plug, thereby encircling the tendon around the bone plug, and it's secured with multiple sutures. And now one can see the prepared patellar bone plug is around 8.5 millimeter in diameter. And this is the graft passage of a folded PTB graft. And you can see the femoral bone plug is flush, still a centimeter of tibial bone plug is jutting out. So this is a very useful technique, and this should be done before you pass your femoral plug and fix it. It has to be suspected on the table so that this fold-over technique can be done on the back table. Tibial plug breakage drill holes or the cutting out of sutures at the tibial bone plug can be a problem. To address this issue, a technique of rescue sutures is being followed. In this technique, number 2 fiber wire is used to place sutures in the patellar tendon close to the tibial bone insertion. 3 throws are taken up. The suture is closed and brought down using 3 passes. These fiber wire offer a good control of the graft in case the wire or threads which are applied to the tibial bone plug breaks, and they can be used for additional fixation on the tibia. One has to remember that the femoral bone is dense, and an initial metal screw can be used as a tab so that a bios screw can be inserted with ease. One should also remember, if you're trying to use a bios screw initially, it can break. In this scenario, titanium interference screw should be kept as a backup. Coming to the size selection, whatever the diameter of the graft or the tunnel, if there is perfect match of the tunnel and the graft and there is minimal gap between them, a 7 millimeter by 20 millimeter screw is selected for the femoral fixation. For every 1 millimeter of looseness, the screw diameter can be increased correspondingly. On the other hand, the tibial bone is always relatively soft. For a matching tunnel and graft, whatever the size of the diameter of the tunnels or graft, an 8 by 25 millimeter screw is selected. Especially in cases of revision, the tibial fixation may need an additional fixation in the form of pillar posts or suture anchors, which can fix the rescue sutures, the intratendinous sutures, to an anchor on the intermedial aspect of tibia. Infrapatellar branch of saphenous nerve. It crosses approximately 3 centimeters below the inferior pole of patella and 2.5 to 2.7 centimeters above the tibial tuberosity. An oblique incision and keeping the incision as mobile as possible and reducing your dissection can minimize in the injury to the infrapatellar branch of saphenous nerve. Donor site morbidity can be reduced by bone grafting the patellar defect, which can help in healing of the defect and also prevent in patellar fractures in the later time. The tendon margins are usually not sutured, and injury to the fat pad should be avoided. But the paratenon is closed because the paratenon closure can help in bringing vascularity and healing of the patellar tendon. It can also reduce the incidence of anterior knee pain. Persistent anterior knee pain could be because of small stress fractures around the inferior pole of patella, fat pad edema, poor healing of the patellar donor site. It's very important that the physiotherapy should achieve full knee extension and good quadriceps control and good gluteal strength. However strong a graft may be, it is of no use if it's not healing the bone in the appropriate time. As you can see here, this is a revision ACL reconstruction done in our Indian football player, along with double Grassley's ACL reconstruction and meniscal repair. So this is the amount of recovery you can expect with a BTB ACL reconstruction. With proper attention to technique and patient selection, one can achieve really good results with BTB ACL reconstructions with minimal complications. It still, in my opinion, is a graft of choice for aggressive sports persons in revision scenarios, and also candidates who are at risk of developing early graft failures following primary ACL reconstructions. To conclude, the BTB graft is still the gold standard, at least for difficult situations. And I'd like to thank Indian Arthroscopy Society for giving me this opportunity. Thanks all for watching this video. Thank you very much.